Dr. Sharma, we are ready.
Yep.
Can we go live?
Yep. And we
Yeah,
are, but
can you
Dr.
see
Mack is
us?
here,
Sure.
and along with the.
Hi, Dr. Mack.
Yep. So, and along with the here, Amit Huda
Show
and
slides.
Sunny Goyal. Parusram is not here with you probably, and Casio Dominguez, and actually Hemant Chaturvedi. Hemant should be here. Come, Hemant.
Hi,
So
everyone.
we all are here. Yes. Tell us. I know limited time.
Yeah,
Dr. Kinney?
the entire case, yeah, will be say is
Yeah.
the 82-year-old female
No freedom.
with dyspnea and progressive fatigue,
Well.
past medical history, multiple comorbidities with hypertension, multiple PCIs, COPD, has had breast CA with the lumpectomy only. And also you see that lung CA and radiation. So a lot of things that she has had for the chest, though not a chest that can high risk anyway. So 60 EF was 61% with severe AS. So medication wise, beta blocker, which she's been on, and anoxipar. So Kath had shown 3-vessel disease, and we did a significant, there was a disease of the RCA for which she had PCI. So this was the transthoracic echo, which had shown that she had a P gradient 56, mean 32, and severe AS. This is the CT analysis. You want to talk on the CT?
Sure.
And you see,
Okay, so the CT looks pretty good. You have an annulus minimum of 18, maximum of 20, a perimeter of 62.2. The LVOT is pretty small there, goes down to 58.3, areas around 262. STJ is again around 26, and the sinuses are 27, 29, and 28. Any thoughts about what valve to use here? From the panel,
Small.
Dr. Sharma, Dr. Mack.
Yeah. Because the small annulus.
Female patient with small VSA and the small annulus area, I think probably like a supraannular self-expanding valve according to the SMART.
Expandable.
yeah, that's one. But what about the calcium? That's absolutely very little calcium, right?
Oversize it a little bit.
Right. Yeah, no,
26.
I think this is the 26.
At the borderline.
No, it's 26 self-expanding.
Self-expandable.
This is,
At the borderline.
So what size would you use, Sunny or Abel? What would you prefer here?
But the
With
LVOT
a
is
narrow
smaller.
LVOT.
It's a smaller LVOT, so it is the borderline for 23 and 26. But LVOT being small, there is more chances of pop-up and embolization. So I think 23 might be okay here. Self-expandable we will do, not the balloon expandable, because of the more hemodynamic favorability.
Great.
All right. Keep telling us what you're doing.
so going back to the absence of calcium is a little concern for me.
Right.
Self-expanding. Yeah, because
Rami, you want to? So this is a cut down case. You can see a lot of calcification on the iliac and as well as the common femoral artery. We did not want to do this as a percutaneous case. So our vascular surgeon, Dr. Tadros, will talk about how he did the cut down and how we sort of do it and how our cadence is.
Absolutely. So if you look back at that last image, if you go back one slide, the minimum diameter is around 3 millimeters, heavily calcified iliac, small aorta. The common femoral is another really important thing. The common femoral is diffusely calcified. So in this case, we utilize a technique where we elevate the inguinal ligament, isolate the distal portion of the external iliac above the epigastric, where it's free of calcium, and we access that area. That area can be easily accessible, especially if you mobilize the inguinal ligament, and it provides you a clean access point, and it often provides much simpler repair than having to manage heavily calcified common femoral. You could access the common femoral, but then you're having to deal with the calcium there. There's a much higher risk of having to do a femoral endarterectomy. So accessing above that calcium, I think, is a good idea. And then in terms of managing the small diameter and the calcium, we used IVL, intravascular lithotripsy. We used a 7 millimeter by 60 balloon, and we shocked the entire thing. Given the amount of calcium in the diameter, we also went with a eSheath, an Edwards sheath, expandable Edwards sheath for this access, and then post dilated that to 7 millimeters with a 7 millimeter balloon. And with that, we were able to get the access needed for this case.
Great.
Okay.
Okay. So, Dr. Kini,
So the same, I think we are 23 millimeters Evolut, right? We are going to be using. So we already up.
so this is
in
the
the
access
sending.
again. We did, Dr. Tadros did the cut down, and then you can see it here, did the IVL just for completion's sake. And looks pretty good. We crossed the valve, and now we're ready to go.
Where is the pigtail?
It's already in the non.
Okay.
Show me all the way up.
Any pre-dilatation or no?
Help me here. You
Low
see
flow,
that calcium
right?
there?
What did you say?
Flow, yeah, low flow, yes.
Mhm.
But I can show you the echo, but after the case.
Oh, good.
You can see this a little crunchy there. So we rotated it gently, atraumatic way.
Now we have to.
Let's go to our view.
Not sort of aligned here because you saw that it was an inner curve.
Michael, what is at your center in terms of sentinel device use? It's a pro sentinel center or selective sentinel center? We're still using quite a bit of number if possible.
What, Sentinel unit? We very seldom use it. We'll use it on bicuspids and we'll use it
150.
on TAV and TAV or TAV and SAV.
Because those are the data support. Overall, the TVT registry only 16 to 18% of cases are being done with the cerebral protection.
100.
Yeah, and it's gradually going down over the years.
Okay.
Go
Looks
in.
very good.
Go in a
Looks
little bit more. Yeah.
Fine. Take
Picture.
a picture, please. Looks very good. We're going to release here. Everyone agrees?
Yeah.
Yes.
Just like almost.
Good. Pace 150.
Okay.
Beautiful. Good. 120. Push the wire here.
This
Push
is
it
the
down.
point with the nose cone, sometimes.
Yeah,
causing
especially the
emboli.
small LVOT. Yeah, absolutely, Dr. Sharma. You have to be a little careful. Yeah.
Back up.
Back up
Okay.
now, please.
So you want
And then
immediate?
let's resuscitate the
Looks
patient.
okay. I hope we don't need to post. What do you think?
Yeah.
Let's see.
1 second. So because we overdrove this, I want to make sure we are good here. Yeah, I just want to, because it's very tight.
So, no time. Fast.
Okay.
All right.
They should show the echo also on one side now.
Sure.
Yes.
You want to do the, Dr. Sharma, I think we may need to post dilate this.
No, the echo. What's happening?
If they can show the echo,
20?
right? We have a lot of echo experts here.
Careful. How did
Give me a
Yeah,
wire.
I can show the echo if you
Picture.
like, Dr. Sharma.
No, we
Go
cannot
ahead,
see it
Stan,
yet.
show the pigtail.
We don't have
Can
it.
you put the echo on?
Yeah.
The echo?
No, we can.
Yeah. So, as you can see, hyperdynamic left ventricle,
Actually, it looks good.
a lot of matter annular calcification, thickened
Underexpanded.
leaflets, immobile, and also thickened ventricle with some bulge on the basal septum with some chordal sum, as you will see, mild MR and mild AI. Short axis of the
It's a
view
pre-one.
of the aortic valve. As you can see, it doesn't open much, minimal AI, minimal PI, some TR here, no significant pulmonary hypertension.
Go to the other
As you
side.
can see,
You may destroy the valve.
hyperdynamic LV.
Give me a J wire.
Normal RV
J wire may be
pumping,
better here.
a lot of MAC
Yeah,
and the
J wire.
chordal sum.
No, actually,
There is
J wire.
moderate
It's just like-
MS from the mater annular calcification,
Never short.
mean gradient of 6.
No, this is okay now.
As you can see, because of
This
the
is
sum, there is
Plus.
no much gradient, about 15 at rest. Annulus was 1.7 by echo. This is right parasternal view, 3.3. Peak gradient was a higher gradient when the patient, before anesthesia, when we did the initial echo. Aortic valve area, 0.9 centimeters square. As you can see,
Safari
stroke
wire.
volume index
Safari.
is 29, so it's paradoxical low flow, low gradient aortic stenosis with indexed aortic valve area of 0.5. So significant and based on the guidelines, symptomatic, this type of aortic stenosis is indicated for TAVI in this patient. And this is subcostal imaging showing minimal small anterior pericardial effusion. Thank you very much.
Okay, now do the
Question,
quick
should we
echo.
dilate or not
Post.
dilate? Let's say.
I think I want to dilate, Dr. Sharma.
Our echo cardiographer here.
No, no,
would you dilate
yeah,
there or
go,
no?
go, do.
So post imaging is not here right now.
No, they're doing it right now.
This post
Yeah.
imaging.
Yeah, after post dilatation, imaging would be better.
Little bit AI, but most likely still the wire is through the valve. No PVL.
Angiographically,
still
look
looks
constrained.
underexpanded.
The valve definitely look constrained angiographically.
Yes. Yes.
Short axis, no PVL. Let's go to apical.
22?
20.
20.
Right? I mean, it's
Or
hemodynamically they're
22.
saying plus minus, just
Yeah, I'd post dilate.
post dilate. All right, the
Yeah,
vote here is
absolutely.
post dilate.
Let's post
Would be
dilate.
better.
Minimum PVL.
Yeah, the frame is very constrained, Dr. Sharma. You see that, right?
Morphologically, it's constrained.
And what size?
20. 20.
2 balloon, 20.
After go to the apical. Apical.
So we're going to go in here.
Okay, 180. Are you there? Hold on.
Oh, so it'll be there.
Go. Where are you?
1 second.
Not yet.
Help me get in. All right, good. Looks good there. You can leave it. You can leave it.
Okay, 180.
Go. Look at that.
Yes, it's expanded now.
Oh yeah, extended. Yeah, for sure.
Okay, off.
Off.
Get us a pigtail. Let's do.
I want to do hemodynamics. Chair, please get the pigtail. Really expanded well. We saw that here.
Oh, hold on. Gilbert, did you have to say anything?
And on floral with 20.
Yeah.
So the waist level is 20, so clearly it was less than 20.
Correct.
So we mentioned it to them. They don't hear.
So the waist on fluoroscopy, we all saw, right? It was very constrained. Dr. Sharma had pointed that out. And even with a 20 balloon, you saw such almost 25 to 30% expansion in the diameter there. So clearly the waist pre-dilatation was barely 16 or 17, in my opinion.
Okay, go.
So apart from, gradients and PVL, we like to post-dilate for complete valve expansion as well.
Oh,
Let's get some gradients.
Open up in advance.
Because that does impact durability of these valves.
You see better, bro? See if it's.
Can I get a flush?
Wire
Okay, let's
related
do,
AI.
Yeah, it's a little bit mild PVL, eh?
okay. Mild PBL?
Yeah.
It's a wire related, I think so.
Okay.
Yeah, maybe let's zero
Okay,
everything.
let's zero.
You can
Change
show
angle.
hemodynamic
You
on
can
the
go to-
bigger screen and the echo both.
Show the
Those are very
hemo.
important, yeah.
It's change the three chamber.
Is a 10 millimeter gradient we are getting.
8 millimeter gradient, yeah.
Yeah.
The-
Okay, let's.
I
take
don't
a
think we
pigtail
should
out.
be more aggressive with the post-dilatation
That's
here.
acceptable, I
valve,
think.
so-
Single digit mean gradient.
Yeah.
Come out.
Mean gradient is okay.
Let's do the aortogram without the wire there.
Now
No,
check
we
it.
did it.
So there's a gradient between the two catheters as well, around 4. So true hemodynamic gradient is around 4 to 5.
All right, show us the last picture of the day. Do the aortogram, please.
Okay,
Sure,
done.
Sharma.
Echo.
Okay, let me, Hafiz, can I just take a quick aortogram? Thank you. Yeah. Sure.
I would just have to say remarkable effort by the cath lab team in all aspects. The fellows, our nurses, nurse practitioners, technicians, and of course physicians and everyone to make 9 cases, 9 live cases in a structural symposium. I mean, people do 4, 5, 6. We used to do 4, then we did 6, but then 7, then 8. This year 9. Maybe next year they're saying maybe double digit.
Okay, let's see the
We
aortogram,
knew
please.
it was coming, but I think time to slow down also.
Beautiful results, beautiful result.
All right. Okay, that's it.
Thank you, everyone.
Fantastic.
Thank you.
Good.